into the chat. Would people like to just give us a brief flavour of what you'd rather see? Just a presentation or more hands-on? I'm suspecting I know the answer to this. I think most people will want this to be more hands-on and more practical based. Yeah, they're coming through. Hands-on, absolutely. I think everybody gets so tired of death by PowerPoint that this is just going to be so refreshing.
I get tired. I've moved away from presentations. I don't know. I just don't find it very useful. After 10 minutes, people more or less switch off, but I do. So
I tell you what I'll do is I'll share your slides afterwards, just in case, so that people have got something to refer to. And then we'll go with the hands-on element, which I think is just going to be so much better.
Right. So, oh yes, yeah. Thank you very much, because it will keep me very engaged. I do like it. Right. So are we going to? I mean, because I know that there was there was a talk just before. So I don't know whether people want 5 minutes break and just want to get up and get some refreshment, and we can start.
Yeah, fortunately, the last one finished a couple of minutes early, so that's what we did. We let everybody go for a refreshment break. So should we give it a couple of minutes, and then we'll get started, and I'll introduce you.
So those who are at their desks in front of the teams, if you guys want to just post a few things here, what would you like me to talk through? Then at least I can, because I'm in a clinic room, so I'm in a very fortunate position today that I can grab the stuff and literally show you, which is hardly ever, because generally all these things happen in the evening from home, and where I don't necessarily have speculum. Yeah, so if you want to type a few things, then I know roughly where we are heading towards.
Yeah, that'll be excellent. I think possibly the best way to go would probably be if you get started, then we'll see what comes up as we go through the chat. That would be the best. Brilliant. Well, regular pessaries.
I thought that would be one of the thing, and it'll be very, very useful to converse about it. So that'll be good.
Right. Well, should we get started then? So, just like to introduce Ms. Shukla, who is a consultant from Woodlands Women's Health. The whole purpose of this session really is just to be an hour of discussion regarding day-to-day questions and concerns that you may have as people on the front line. So it's really nice to have an expert with us. So please keep that chat facility running, and we'll try to get through as many as possible during the session. And yes, certainly something a little bit different from what we've been used to in our PLT sessions. So, Ms. Shukla, over to you. Many thanks.
Right. No, thank you for arranging it. It's been a while, because I think post-COVID, all of us have become so busy, and it's just like literally we can hardly keep our heads above the parapet and on a day-to-day, like it's like a survival, or sounds like survival. So this is quite refreshing. What I was thinking today, and I know that considering that we have quite a few people we are together today, I would just like to, first of all, I just want to brief you about what is available when we were obviously at Woodlands. It is more or less nowadays, when we started years ago, and how restricted the services were, as compared to that, it is more or less now parallel services to, all hospitals. I think all 3 hospitals in the county, they do run parallel service for all patients, especially when it comes to gynae. I don't know about other specialities, but probably would be the same. From my point of view, I try and do it. So I see, apart from just two things, colposcopy and part of fertility, like, the actual treatment part of fertility, I see all the patients. I'm quite into the um, is kind, quite broad based, and I would like to keep it that way. And the main I believe that yes, we all have to slightly subspecialize, and my subspeciality is in urogynecology, prolapse, and incontinence. But at the same time, the type of the patients we treat, it's all going to be significantly overlapping, right from the young to old age. And from the presentation point of view, I would have what I normally divide gynecology is in a premenopausal, like young age group, reproductive age group, perimenopause, and then postmenopausal ladies, and how different age group will have slightly different issues, but still there is a huge overlap. So when you see the patient, obviously we all would want to see the patient as a whole, and to kind of segmenting it into, you have come to my clinic only for such and such problem, it doesn't work very well, because it just kind of all intermingling. So if I just start from, as if, for any patient with gynecological problem, just to make it very clinical, when they come in, my practice would be that first of all, to kind of do the very detailed history, so you can get the idea of where the problems are, because patient might have main problem as one. For an example, I would say that if perimenopausal lady has come to me for the prolapse, and which is mild to moderate prolapse. So if we take a hypothetical situation of you sending me a patient who has mild incontinence, urge incontinence, mild stress incontinence, little bit of prolapse, but altogether that's making her kind of think that, okay, I need to do something about it. But at the same time, when I do the history, I would ask all the detailed question, right from the her age and her parity, and if there were any major issues, and still it takes a very short time, but any major issues around the delivery, because that's going to give me an idea what might have gone on, which has led to, or which could have led to, the prolapse and incontinence, versus menopausal symptoms, any previous surgeries, detailed aspect of her presenting complaint, which is what type of the incontinence this is going to be, and I'll come to that in a minute, how to differentiate and how to look after each aspect, versus is the incontinence major issue or prolapse is major issue. But when I do the history, and if it is very obvious that there is, perimenopausal symptoms are kind of setting off, then one of the extra thing I'm going to start thinking in terms of, okay, am I going to give her, are we going to talk about HRT? Because obviously HRT is protective towards this, these symptoms and deterioration in the symptoms, which you can easily prevent. So you won't start talking as a primary subject to these patients about HRT, but if she had that additional issue, which is causing her the bother anyway, then I would just think that, okay, let's just approach the subject. What are her thoughts, and would she consider that? Because in that case, overall, the general well-being is going to be quite good, and it's an extremely important supportive treatment. The deterioration of symptoms can be kind of, the pace should be reduced. You can't take it away completely, but the pace can be lower. So apart from the whole broader view, apart from just concentrating on what she came to me, I would just like to just know about all these things. If this woman had moderate prolapse, and I'm kind of, or we are talking about, okay, which direction we should head towards, like carry on with the ring pessaries and everything, versus are we talking in terms of surgery? If it's kind of going 50-50, that both the aspects are very good, but which one do we choose? Then her menstrual history is going to be very useful, because if she's already having issues with menstruation, and if they are kind of additionally making the quality of life significantly poor, then that factor slots into decision making. Ultimately, obviously, it's the patient who decides, but the options that we consider do change as you go along if you have this broader view. So I still believe that gynae is actually very small to to segment it significantly, that to box it up into different aspects, because there is a huge overlap. I mean, simple things like if patient has a prolapse, and the same patient has recent history of, persistent HPV positive, a borderline or low grade dyskaryotic smears, and we are kind of thinking about, okay, are we going to do just a repair, or are we going to do vaginal hysterectomy and repair? Then that factor is going to come into that decision making, that look, we have been trying to deal with your cervical issue as well as now this prolapse issue is kind of there. So, and we are already talking about surgery, so which surgery we choose is going to be kind of, these additional things will come into play. So overall, what I'm trying to say is that keeping the practice broad-based has helped me and my patients a lot, because that's when I can concentrate more on patient as a whole. Plus, it does definitely make it less boring, and it kind of serves the population very well. And this is where detail, and I know that in the primary care you don't get enough time to do the history in one go, but at the same time you guys are in a very privileged position that you have the whole history of the patient there, because you know their background history and how many times they've come to you with different problems and everything. So one good thing in your situation, I feel that that you can do is just doing the slightly detailed history and just main salient points, but also when you're referring the patient, just providing us with this sort of information, because it comes really handy, and we don't necessarily have nowadays access to all these information, because patients are seen in different hospitals at different times and not all the records are getting together. So we do really heavily rely on the information that we get. I certainly do read your letters really carefully so that I get full information apart from talking to the patient. So far so good. Anybody, any questions? I do have kind of a pro forma and things that I actually give the patient to fill up, and it is kind of designed, and it has been checked by patient information group, and it has been approved by that. So if anybody wants that, you can email it to me and I can send it to you. You may tweak it your way, but that is, and again, it's extremely handy because it just then gives you automatically that level of information without having to spend time. Literally, you can scan through it and everything is in front of you and it's given by patient. You just need to then add a few bits to it, which patients may not know. So practically, I do the parity, menstruation, menstrual history, smear history, medical history and surgical history, because obviously that comes into, when we plan for the surgery, those are the extremely important things. Very simple changes that we have kind of, recently I've seen that there is, I'm digressing a bit, but I've seen significant increase in referrals where patients are getting recurrent thrush, which are not, which is not kind of responding to usual treatment. With the diabetic patient, we always knew that they are quite prone to the thrush, but the new tablets, new treatment, and I always can't pronounce the name properly, so please don't laugh, but it's empagliflozin or along that line, and that is the one which actually increases the risk of recurrent thrush significantly. So that's when you just kind of know that your chances of successful treatment are slightly different, and you may have to employ much vigorous strategies for recurrent thrush as compared to somebody else who is not on such treatment. So these are the tiny little things, but which are extremely important for us to know. I try and run my first clinic appointment as almost to know everything about the patient, and also as more or less one stop, where I wouldn't necessarily say that it is like one stop everything gets better in that time, but everything gets covered during that appointment, including I scan all my patient if needed. I scan them by myself because I can correlate my examination findings, my history, and my scan findings kind of together. I'm just writing because some of you need the questionnaire, so I'm just going to put myself a note, and then what I can do is just post it to, probably we'll have a common point of contact, and then they can transfer it.
If you can just send it through to me, that would be the easiest
yeah, I
one.
can, and then you
Absolutely.
can just send it off. Yeah, no,
Yeah.
that'll be quite helpful.
Yeah.
Right. So that's kind of a starting point where patient journey starts. If I mean, looking at this, we probably I think one of the question was about the pessaries, and I think it's very relevant in your practice because you do see quite a lot of patients, and we do rely. I mean, if I've done the pessary, and if patient has a problem, and if they come to you, then then it's quite nice to know that where we are. So shall we just, if everybody's happy, then I'll spend just about 5 to 7 minutes talking about the pessaries. So huge number of different types, different style, and they do have slightly different function. Nowadays, we are actually quite lucky that we have different material as well. So if we think about our routine Portex pessary, which has served us for millions of years, and it's very, very useful and still remains extremely useful. It's very effective. It's so cheap, and hence it is quite important that we do carry on using it. When it comes to silicone pessary, and actually, I mean, I'm in the middle of kind of writing my whole experience with self-management of the pessaries, which I started the project about, I think just before COVID, I started that project because we were getting kind of inundated with patients in pessary clinic. And by that time we had silicone pessaries available. So I started teaching patients how to insert it and how to take it out. And initially I was just like, okay, we will teach only kind of, young fit patients, and then we'll see how it goes. And gradually that is now expanded. And to my amazement, within like literally a minute, I can teach if patient is willing. I would never ever just force it on them. But my rationale of teaching them is that, especially first time when they go out of the clinic, and typically at Woodland I run the clinic Saturday, and then Sunday there is nobody there. They can email me, they can contact me, but obviously I'm not 24/7 on the email. So if there is any problem, then at least, if nothing, and if they're really uncomfortable, then they can at least take it out until I can see them again. And then in long run, my intentions were that I have to see the patient less often, more from the patient's perspective, because all patients, you would have noticed that with pessary, they do get slightly higher amount of discharge. And it's not very nice. It is actually quite a bother. And rather than them having to put up with that, what I tend to advise them is that every couple of months, and depending on, right, if it's a, and I just always tell patients that you will design your way to take it out. They don't have to take it out till I see them next time. But if they do, then they will all develop their usual things. With the menstruating women, I just normally say that just take it out during the time of menstruation, not because they have to, but it automatically reminds them. It's easier to use tampon if they are using tampons or menstrual cup or whatever. Plus, it doesn't get discolored, because it does otherwise with repeated, blood around it, it can get discolored, and doesn't matter, but it's not, when they take it out, it's not a very nice looking thing. So so I normally say that take it out, and then it gives them natural break. With postmenopausal ladies, I normally say that maximum by second month, take it out, leave it out for a week. It gives them usual break, carry on using vaginal estrogen, and put it back in. And about 60 to, sorry, just give me 1 second. I'm really sorry. Sorry. Yeah, so it's generally, and I get them to use vaginal estrogen routinely. Which pessary is better? I mean, size-wise, obviously, size-wise. So with the pelvis, what I tend to do is, with the vaginal examination, I normally go all the way to the symphysis, to the sacral promontory, and then just lift my finger slightly. I hope you guys can see that, and just see where it is, kind of where the symphysis pubis is. And that length is actually what I need, because pessaries, I mean, I think common misconceptions about the pessaries, it just simply stretches the vagina. It doesn't. It sits on the sacral promontory and and the symphysis pubis. So actually, when the patient is standing, it's kind of, because our pelvis is tilted, it is at 45-degree. So once I put the pessary in, plenty, and you would have experienced the same. Plenty of ladies just say that, oh, I can feel it. Yes, they would feel it. They will feel it under the pubic bone, because it kind of stays at a 45-degree angle, and that's the angle our pelvic floor, our pelvis inlet is. So that's how it's going to stay. It just kind of goes beyond the levator plate and stretches and lays itself onto these two bony prominences. So that's why it's what we used to call it obstetric conjugate. And then you roughly know that where you're on your finger every pessary sits, and there's absolutely no harm initially if you're doing it. Then absolutely no harm that you put the pessary and just measure which size fits the best. I'm just going to grab one for you and show you how to insert it. So if you find it very stiff, then, so this is the dummy one that I have kept. So if you find it very stiff, then you can run it under warm water, not hot, not boiling hot water, but warm water, and it just softens up. Silicone pessary does have, it's very expensive, so I won't open that, but silicone pessary does have a little groove made on both the sides. It's like at 180-degree, and it just kind of folds along those grooves really well. And what I tend to do is just squeeze it and put it on. So if that is the kind of posterior fornix, then so usually you need to run it along the posterior wall of the vagina. So you rest it onto the posterior fornix and just literally slide it as high as it goes. And then after a little while, it just automatically opens it and it falls it in place. And at that point, it'll be just slightly like this in the vagina. So you can just slightly feel it at the opening, and you need to push it in and tuck it under the symphysis pubis. And that's when it sits the best. If your patient, there are a couple of really good tips. If your patient suddenly feels quite, so the uterus is there, and if they feel quite uncomfortable for a little while, then you need to check, because if the pessary goes in front of the cervix, the far end of the pessary, if it goes in front of the cervix and literally kind of pushes it down, that is very, very uncomfortable for the patient. And that patient won't settle till you have reset the pessary. So you have to kind of go all the way in onto the posterior part of the pessary and just push it back a little bit and flick the cervix. So cervix kind of comes into the middle, and that's where it should sit. And this is how it will then sit into the pelvis. Portex versus silicone pessary. Portex is much cheaper. Silicone pessary is much more expensive. I think it's £1.50 versus £35 starting point, and then if you have the one with the support, it's different, and etc. But anything apart from ring pessary is anyway more expensive. Advantage of silicone pessaries, which we have entirely moved on to, is the number of visits, because this one we normally, according to NICE guideline, you change it every 6 months, but with the silicone, and if they're self-managing, it's just once every 8 to 9 months. Sometimes once a year, depending on how successfully and how confident your patients are. As long as we can give them the access, if there's a problem, then I think they're quite okay, and they do manage quite well. When do I use the one with the little diaphragm inside is if there is a significant uterine prolapse, then because otherwise the pressure of the uterus is going to push your pessary down, and it does again make it quite difficult because the cervix comes through and it just brings the whole thing down. So that's where I just use the one with the diaphragm, so it holds the cervix up. Where do I use the Falk pessary, which is like a dish? Falk pessary just creates kind of we used to use the shelf pessary, and shelf pessary was it's a black coat hanger, literally it's a black coat hanger like pessary. We hardly ever use it now, but it was very useful where the prolapse is quite elaborate and you really need kind of you need to hold a more or less push and keep everything in place rather than anatomically giving some extra help. It's just like literally physically keeping everything inside. It is more uncomfortable. It's tough, like more stiff the pessary, more chances of erosion. Larger the surface area, so anything which are space occupying pessary, like donut, which is literally like a big donut. Falk is like a dish, but because it has the middle bit which also stays in contact with vagina, they all have, because they have larger surface area, they're more likely to cause erosion. So those are the patients where I kind of probably get them back more quicker. We have a patient with a Gellhorn pessary, which I have not come across previously. Gellhorn is again, I have seen that more and more people are using it. Again, I think the whole idea, so I'll just show you, because I'll show you through the packet. The concept started with that, so it's an idea of focal stress incontinence, where, so this is, I don't know if everybody can see, it's the one with the little knob, well, not little knob, quite big knob actually, there. You can't see the speaker. Okay, this pessary is, the whole idea was that this knob will remain under, and it was the idea from the shelf pessary that this knob remains, it kind of goes under the urethra and kind of pinches the urethra and keeps it up. Because sometimes what happens is that those who have severe prolapse would have severe stress incontinence as well, but that stress incontinence is hidden. It's called occult stress incontinence. That means when the prolapse is down, they can't wee, but they don't leak either, because bladder is all kind of completely kinked onto itself. And the moment you put pessary and everything is straightened up, this the valve deficiency, which is already there, it's going to declare itself, and at that point they start leaking a lot. So you have taken them out of one problem only to experience another horrendous problem. So that's where this sort of the pessaries were designed so that they can just go under the urethra and pinch the urethra and reduce the leakage. Gellhorn is not doing it very sufficiently, but with the shelf pessary, that knob was just slightly curvy, so it digs into the urethra. But again, they are all kind of makeshift. By that time, you really would want, well, I would want to offer surgery and get them kind of, on their way, making them better. So from the pessary point of view, you have space occupying and you have supportive. Supportive are just the one where they just stay quite higher up, whereas space occupying are just literally, they fill up the vagina one way or another, like this Gellhorn or the cube, literally like a cube or a donut, and they just fill up the space so nothing can come down, including uterus and vagina. They compromise the so they compromise the sexual function, whereas supportive pessaries should not compromise the sexual function. It is always a good idea to use vaginal estrogen when you give pessary, because it does reduce the risk of erosion, ulceration, but you can't take that risk away completely, and hence we need to see them regularly. Silicone pessaries are there to be reused, washed and reused, and they last for 10 years, according to the company. So in some ways it makes more sense to have silicone pessary, because you can reduce the number of follow-ups, which automatically just pays for itself, and also and they're much nicer as well. They're softer, they're much nicer. But some patients, somebody has put that patient prefers Sportex pessary, which is fine. I've seen that women know what helps them, and just tiny little tweak. Sometimes they talk about the size and just like 3 millimeter difference, but they can make it. They know that there is something different that has gone in, because they're so used to of it and they're so sensitive to this area. So anything else, anything more you want to know about the pessary? If any question appear, I'll take it. Otherwise, I'll kind of move on to incontinence I was talking about. So 2 different types. Overactive, I mean, obviously 4 different issues, but most importantly, we need to first rule out that this is not an overflow. Patient is not in horrendous retention. That's the first thing. That's one red flag. And second thing is massive prolapse, which can cause overflow incontinence, or which can just cause very small frequent voids without any warning, because the bladder is not, it kind of moves about as the prolapse move about. These are the things that hematuria, recurring infections, all those things we need to rule out. Other than that, with the overarching thing which helps with the prolapse, any pelvic floor related issues, is pelvic floor exercises, lifestyle changes. Nowadays, weight management, and that's where I think I'm hoping that all these injections and newer things coming in and everybody harping on about it, we are going to be benefited. In fact, I've started putting patients slightly more on hold, saying just see whether you can get help. So that we can optimize that surgery. The question is frequency with which you can change a ring pessary, please, as presently changing 6 monthly. 6 monthly is fine with the normal Portex pessary. With the silicone, you can go for kind of bit more. And if patient is self-managing and if they're confident, as the time goes by, you can increase that duration in between. I mean, 6 months is kind of a nice guideline, but you have to reduce it in somebody who is severely atrophic, who can't use vaginal estrogen, who is getting a lot of discharge, or who has Falk pessary or any other space occupying pessary, because they are bound to get erosion if you leave it for too long. So it's all kind of who the patient is and who, what pessary is and what they have done. So if you start thinking that, when they come back to you and if they're massive erosion after 6 months, then next time you want to see them at a 4 month. And then you may say that, okay, look, take it out for 2-3 weeks prior to you come in, because automatically, even if they have erosion, it would have healed and you can just check it all out, make sure everything is fine and put it back in. So very practical kind of, but 6 months is in general guidance. And then you will vary it. More you do, more obviously more useful it is, because your experience will get into it and you'll be able to manage much better. So coming back to incontinence, just usual advice about fluid. Nobody drinks enough in this country. Nobody drinks right type of because we are so used to of our cups of teas and coffee. So all decaffeinated, non-fizzy, very kind of, not very acidic, mainly water basically. And amazing number of ladies come with no kind of, change in their lifestyle. And when they say that tablets are not working, and you just think your part of the deal is there as well. And which is where it does at times become frustrating, because you're bumping up the tablets and they're not getting better because they're not doing anything for themselves. Bladder retraining, again, that's very much a personal commitment that patient has to make. and most of the women are not very good at doing it. But basically, very simple concept if you give them, rather than going into any complicated stuff, is every time when you want to go, just go and do one extra job before you go. Always just do it. And it's always, that means just retraining bladder not to take over that phase. And what happens when they get urgencies, bladder has made, so bladder ideally is like a balloon, and it should just stretch and keep the pressure almost to zero when it's filling up, to the extent where it comes to its maximum capacity, which is about 400-500 mils. And that's when pressure slowly goes up. So we get warning, because brain has this different levels where it keeps on getting you the signal that you better think about a toilet, to you now start look for the toilet, versus you need to go now, versus you have no time. So it gradually goes up, whereas when bladder becomes overactive, it just suddenly makes a squeeze. And that squeeze has no warning, because there is no gradual rise in pressure. It has suddenly gone up to significantly high. They leak, and then it all settles because they've leaked it out and the contraction has settled. During that contraction, if they have a good pelvic floor, they would squeeze that pelvic floor, stay there, not let it kind of, leak. And then gradually bladder learns to expand more and more, and these contractions become less. One of the very common thing is, overactive bladder is very, yes, it's menopausal aspect, but it's kind of, it's a big circle where perimenopause and menopausal ladies, they have very different biome, which means the number of bugs and types of the bugs and everything in the vagina, because hormonal environment has changed. That then makes them more prone to infection, urine infection. Bladder gradually develops very low grade rumbling chronic infection, and that bladder then becomes overactive, and then with time it just becomes a habit of that bladder, that it's going to remain that way. So this is where you will see my practice. If you read my letters, it would be, if I have slightest doubt about chronic infection, I have very low threshold of putting them on the low dose antibiotics, because actual overactive bladder is not a cause, it's an effect of something else, which is menopause, chronic infection, habitual, and sometimes other psychological aspects like anxiety and everything. So you have to address all those things along with, yes, fine, I'll treat it with anticholinergics, but my aim would be that this lady should not, as far as possible, should not end up with lifelong sulfonylurea, because it's not very nice to be on that, plus it is connected to dementia and everything. So you would want to take them off as far as possible within few years. So this is where vaginal estrogen, all the behavioral changes, building up the pelvic floor to the extent where it can hold this sudden rise in pressure, drinking right things, and reduce and changing your hormonal environment and reducing the risk of infection. So these are the things that they are very important with the overactive bladder aspect. And with the stress incontinence, again, ultimate answer is going to be the surgery. But prior to that, everything else that I said, very, very importantly, weight reduction, building up the pelvic floor, drinking right type, and developing the habit of just, doing regular pelvic floor exercises. There are continence devices. Can the patient use E-string with the pessary? Yes, they can use E-string very easily with the pessary. The only problem is that, because E-string needs to be changed more often, so probably you would want them to self-manage that. So from one of the things which is quite commonly asked at the moment is stress incontinence aspect. So in this area, certainly I provide all the possible. So obviously meshes are gone now, TVT is completely out of question, but we can still very effectively treat, because I do corpus suspension, pubovaginal slings, and bulking, all three of those things. So patients do get quite wide range of treatment options. And I'm very, very hopeful that very soon I'll be looking at laser, because laser vaginal laser is very upcoming with urogynecology for mild to moderate prolapse and incontinence. So very soon that will be something that I'll be looking at. Botox is very useful for an overactive bladder. It's basically a neurotoxin which just relaxes and paralyzes bladder. So we use it in a dose where it's paralyzed just enough to blunt down those contractions. I'll tell you about the laser treatment. So Botox basically just blunts those massive contractions that bladder has learned to make, and it paralyzes it and keeps it that way for a certain length of time. And then we have to keep repeating it. So Botox, in some ways, it's a very good treatment, very effective in taking patients off these medications. And what I do is to increase the duration between two treatments. As the Botox is wearing off, I put them again on some form of the anticholinergics while they're waiting for the next dose and then next dose. And that's how, but I have huge number of patients on Botox now. And it does work. It doesn't work in everybody, but it does work in about 60 to 70% of patients. And where it doesn't work is always related to chronic inflammation and chronic infection. Coming to the laser, the theory with laser is that it causes the microtrauma in the submucosal layer, and wherever there is trauma, it just heals and it encourages, because any healing is going to bring angiogenesis. So new blood vessels come because tissue has been damaged, and it also increases or encourages the formation of elastic tissue. So what research shows in very simple terms is that it basically improves the elasticity. What I have known, and I would say known because I have very limited experience. Only when I go and work overseas, only then I get laser, because it's not a norm yet here, but it's coming. London has few clinics, but other than that, there's none in the country at the moment. So we might be kind of one of the very few areas outside London where we may have clinic if everything works out well. So practically laser, it just literally creates little holes into the tissue, and when tissue heals, very useful for mild prolapse, maybe moderate prolapse along with other things. And these are the reports that we read all the time from across the Europe, where it's used in massive number of other things as well, but we will keep it to only urogynecology. I mean, it is used hugely in cosmetic gynecology as well, so, but that's a different thing. So that's about urogyne in a nutshell. Now, I don't know, I had other couple of things. I mean, we can talk about menopause and HRT if you have, but I think if you guys have had recent updates and everything, and if there are not many questions, then that's okay. If you have any questions about smear program or you know, the things like menorrhagia, fibroid, endometriosis, pelvic pain, I just need one or two guidances from whoever can get to the keyboard first. Or if you have any questions, then I can take them. Anybody? Nobody? So one of the question was that if somebody is on HRT for 6 months, I'll find the question. It was about some bleeding on HRT and what to do. So obviously okay, chronic pelvic pain pathway. Yes, I can talk to you about it. And cervicitis resolved on its own. Okay, so I can tell you both the things in a minute. So coming to HRT and bleeding, so what my usual practice is, obviously when you introduce HRT, it is going to, no matter what age, but it is going to just change the system, change the hormonal axis. So initially you are going to get bleeding, and I always tell them that you will hate it before you like it. because no matter what it is, but it changes your mood, changes the mood. It causes a side effect. Body has suddenly recognized that new hormone has come. It will bleed. General guidance is that up to 6 months, provided prior to that the lady has not had any issues. So it is extremely important to screen that out before you start HRT, that there is no risk factor. If somebody has been diagnosed with polyp or or as it is, if they have significant menorrhagia, fibroids, any of those things, then please get them scanned, at least to have a baseline so we know where we are. But if they have been bleeding for first 6 months, then I would just take a note of it, but wouldn't do significantly anything, because otherwise you'll be investigating these ladies forever. But anything out of 6 months, or if they were investigated for any other reason and have then gone on to HRT, and if they start bleeding again, everything else, if everything else prior to that was completely fine and ruled out, then I would wait for up to 6 months. But after that, I would certainly at least get the scan done. For 2 reasons, ovarian and endometrial thickness. That's the standard. What progesterone would you suggest for a postmenopausal lady who's bleeding? She was on Conti for 6 months and then changed to utrogestan, but still bleeding. She has been reviewed by gynae. This is where I mean, I've seen that when it happens a lot at the moment, and in my opinion, we are giving progesterone with utrogestan. It is a very good progesterone, very safe progesterone, but we are giving that as a tablet, and we are giving everything else through transdermal. And I think that has increased the risk of irregular bleeding a lot. And we see loads and loads of patients. I think scan is very important here. So gynae has seen, so they would have established that womb lining is very thin. You can increase utrogestan for a short time. You can probably add northistrone for a short time. But in general, if you want long-term solution, then probably you'll have to go for, if endometrium is very thin, then you will have to probably suggest that Mirena would be a good option, because Mirena is the one which settles these ladies much better. But some patients do have issues around Mirena. They don't want anything apart from utrogestan because it's supposed to be natural progesterone. And it is quite hard to, probably reducing estrogen might help in such cases. Because always remember, the endometrium will bleed if it's too thick, and it will bleed if it's too thin as well. And if you have too much of progesterone around, then it will bleed, because progesterone makes it extremely atrophic, very thin. And or if you have higher amount of estrogen, then it will bleed, because there will be relatively slightly thickened endometrium. So this is why it is important. But Mirena, straight answer to this question, which you have asked me, Jane, is Mirena would be a good idea. If someone has Mirena fitted and not bleeding, how do we know when they can switch to continuous HRT? They will have I would just put them straight on continuous HRT, because Mirena is there. So it's going to give continuous anyway. So you just plonk them onto estrogen patches. So that's there's a question about incontinence bladder training devices and that. So it's basically pelvic floor trainers, and yes, they are very effective provided they have an awareness of their pelvic floor. So check their pelvic floor. If they can make a good squeeze, then, and very simple devices are quite good. I mean, I quite like the pelvic floor trainer called LV, because it just, you can see it on your phone screen how good you're, and it almost becomes a challenge to yourself that you build up your pelvic floor. But any visual feedback I have found very useful, because otherwise most of the patient, they can just kind of brace the pelvic floor along with their gluteal bracing and things like that, and that's not a very effective. So any visual feedback, where if they put a cone in and then the stick which goes up and down, or LV where they can see their contractions via Bluetooth on their phone screen, and anything in between, very cheap to very expensive, whatever suits them. Carrying around the weights and gradually increasing the weights, all those things do help. So yes, but not kind of, they don't need to go on to massively expensive devices. I'll just take this chronic pelvic pain pathway. So when you say pathway, And if it's a referral pathway, then I don't think we have any referral pathway. We haven't designed any that I know of, even in the past. But in general, chronic pelvic pain is always should be seen. My approach to chronic pelvic pain is pelvis has, and it's always, even if it's known endometriosis, I always tell patients that pelvis is not just reproductive organs. It is bladder, it is bowel. 80% of pelvic pain is either due to bowel or bowels are making it 10 times worse. So if you have read my letters, I spend a lot of time with them to just get the bowel side sorted, as well as addressing their issue if they have endo or anything else. And I mean, bladder rules itself out quite easily, quite at the early stage, because if they don't have any pain in the suprapubic area, any micturition pain, or hematuria, any of those things, and you know that it's not going to be IC or any so interstitial cystitis or any bladder related issue. But bowels are always going to join in with endometriosis, pelvic inflammatory disease, pelvic inflammation, menstrual pain, you name it, bowels will join it. So chronic pelvic pain means you address the bowel, address the issue. So calm down all the systems, all the three: bladder, bowel, and pelvis, and do all the basic work. That means from the reproductive point of view, use of hormone and shutting off their system as a trial. Bowel side, just make sure that they have very simple everyday type 4 stool and they shouldn't feel bloated. Bloated bowels are painful bowels. Only one question will tell you, are you bloated? And they would say, yes, I look 6 months pregnant by the time by evening. The only organ which can do that on a daily basis is bowel. That means the majority of the pain is there. And lots of water, very small amount of something more natural, lifestyle changes, getting rid of any fermented food, getting rid of dairy if that is making them worse. So just concentrating on that aspect, along with, obviously we need to them, because they all will have endometriosis in their head. They are convinced that they have endometriosis. So you can't discount it till you have proven it. So cervicitis, does it sort of, so so it's about the kind of terminology as well. Cervicitis will more direct towards it's an inflammation, so there might be an infection. But cervical ectropion, that means the lining of the cervix which has come out and has I don't know whether you can see more properly on this model, but so you would have, so that's the cervix, and internally you will have more, I think this is very small, but I don't know. It's inside of the cervix will have endocervical lining versus ectocervix. And I always explain to patients showing the hand that this side is much more kind of, delicate as compared to this side, or on the lip, exactly the same. Internal lining is much, fragile than the external skin of the lip. And if it is pouting out, then they would have more discharge and they will have contact bleeding. Whereas cervicitis is where you will see that it's the same tissue. It doesn't look like endocervix. It's just like very inflamed. And sometimes it's very much strawberry appearance, we call it, where it's kind of patchy, just points, red points everywhere. That's very much GPS infection. And that's sort of the things where they have more inflammatory signs around as well. So in the vaginal skin, and they would have more discharge, which looks more like bacterial vaginosis or anything. Then you have to treat the infection and see what happens. Whereas this one, either you give progesterone and it might just draw the endocervix inside, so you can give them hormones, or if they have no symptoms, you don't have to do anything. So I hope that answers your question, that does it resolve on its own? If it's ectropion, it can do, especially perimenopausally, because once they become progesterone dominant, it just goes. If they're on minipil, it will go. If they have Mirena, it will go. Whereas if they have inflammation, then no, you do need to treat it. You do need to change the vaginal environment as well, so that cervix doesn't get affected. I'm just going to kind of go down the list and take few questions, because we do have a little bit more time still. So you know, there was a pathway with psychologist access. I honestly don't know if there was. So there is a counselor for chronic pelvic pain involved, and we are trying to set up counseling services. We are not being much effective at the moment from that point of view at NGH, because we just don't have enough resources for this counseling thing. But yes, for proper chronic pelvic pain, that is extremely important aspect, because those are very very difficult conditions to treat without any other. But I don't think you can make them better just by one or another. You need the full package of it. But at Woodland, we do have psychologists, and I do use them occasionally. And now I think she's going to be allowed, or hospital might have some say where we can very limited access, but we can access them. But Woodland certainly has psychologists who is quite happy to see these patients, but not without our input. So probably we would still be, gynae would be first port of call, and then we can refer them once we have given her primary, once we have ruled everything else out and have given the primary plan of management. I had ladies ask me about incontinence bladder training devices, so we addressed that. Medroxyprogesterone preferred over northestrone for ladies wishing to prevent menstruation for holidays. If it's a very short, I think northestrone actually is very effective. So if it's just like, if you're going to give it for less than 4 to 6 weeks, maybe up to 8 weeks, then it's fine. But if they're going away on a holiday for 3 months, and if they constantly don't want to have period altogether, then I don't think northestrone is a good idea. In that case, earlier, so you need to have a longer run before they go on holidays, because medroxyprogesterone will take longer to suppress the hormonal axis, but then you can continue for a longer time. But that's true for mini pill as well. But for quick action, northestrone is very good. Right. So anybody else, anything else that I can say about gynae? I mean, as I said, the strengths that what I'm quite proud of at Woodland, because everything is available. I've got scanner which is always in my room. You know, when I do the clinics, we do all. I mean, I do all my diagnostics by myself, including urodynamics, cystoscopies, Botox, everything. And hopefully soon we will have perineal clinic access, not at Woodland, but in general in this area as well. It's literally not too far future, but for all these postpartum ladies, will have perineal services. That will be another strength added into the area. So it's all going good. Fibroids, again, you know, mainly surgical. Unless patient is quite close to menopause, then we can either wait it out, but be very careful in putting them on HRT. Not that we say no, but they might have more issues, and hence, if they go on HRT, then it would be quite nice to have a screening ultrasound scan. And rather than sending them to, and this is not just, I'm saying it because I want to see everybody, but rather than sending them to sonographers and then sending them to us, if they come directly to, I mean, I scan, as I said, all patients by myself. So they get both the things done, and then we can have the plan of management as well in the same appointment. So it's kind of, it just ties in really well together. If they need to if they need to have a biopsy or whatever, then we can all just, it all gets done in one go, in one clinic appointment, and everything is just tied. All the loose ends are tied before they go on HRT, which is a major issue at the moment, because otherwise it just either delays them or it. So utovolan has the same efficacy as northestrone. Oh, Norit. So they both are northestrone, isn't it? 5 milligrams. So they should. Right. Any more questions? Any more that I can help you with?
I think that seems to be it, I think. Thank you so much. That was really, really, really informative. And I'm sure if we get lots of other questions, we'll be in contact. That was really, really good. Thank you.
No, that's fine. So what you can do, I mean, what I'll do is I'll just send the question and I'll put a thing. So I'll send it to Craig. And if there are questions, if you just put them in one email, then I can just kind of give the answers to all of them and then send the same email back. Then you can distribute it.
That's brilliant. Thank you so much for your time this afternoon.
Great. Hi, Debbie, wherever you are. I've just seen your name. She's my nurse. Right. Okay. Nice to meet all of you. Thank you very much.
Take care. Thank you.
Wonderful. Thank you so much.
Thanks a lot. See you. Thank God I didn't have to do the presentation. See you. Bye, everybody.
Thank you.
Bye.
That's the end of our Gynaecology PLT today. I just wanted to say a big thank you, obviously, to all our speakers, but for you guys attending. Any feedback is really great for me and Craig, or any topics you want to see moving forward, please do let us know. Craig will be sending out all the certificates and various bits and pieces, so please do make sure if you don't receive it that the link that Craig will put on the website, you can click on that and that will let him know. Just pop your email address in, and yeah, just have a lovely rest of your day.
Excellent. Thank you very much, everybody. And just one last thing from me. I notice that it looks like the mandatory training for the Oliver McGowan is going to be going ahead, and they are going to be using PLT time for that. So we will keep you posted, but it looks like it's going to be 2 half-day sessions that will be face-to-face, and that is mandatory for everybody. So we'll keep you posted on that one and let you know what's happening. But otherwise, thank you very much from me as well, everybody. Take care, and we'll see you next time.